good. All right, started the timer and here is your question. Yes. Right, so if you have read and understood, considering the history-taking station, kindly begin.
Hello, I'm Dr. Dafer, one of the surgical doctor. Could you confirm your name and date of birth, please?
I am Mr. John. I'm 54 years of age.
Good.
Nice to meet you.
Thank you. The date of birth will be
No need.
1965.
Yeah.
How can I help you today?
Doctor, I'm having difficulty in swallowing my food. It's been there since the past 10 months now.
Yeah, it's hard. I'm sorry to hear that. Could you tell me more about it?
I guess it started somewhere around 10 months back.
Yeah.
And it has been increasing since. The discomfort is more now.
Yeah, so it is started about 10 months. When it's start? Sorry.
How? Yes.
How it's start?
10 months back, I initially had difficulty in swallowing.
Yes, it is just for food or fluid.
This was initially for solid food, but now over the duration of 10 months, it's also for liquids now.
So it is progressively now for solid and liquid, or just for solid now?
Both for solid and liquid now, doctor.
Does anything aggravate that?
I cannot think of anything which does that.
Does anything relieve that?
Certain times, initially, when I would try to drink a little liquid, it would relieve it. But now I don't think it's that's happening as well.
Yeah, I understand that. So does it associated with the feeling of the acid in the back of the mouth?
Not always. I used to initially have it, but now no.
Yeah. Does it associated with bad odor in your mouth?
Yes, I sometimes do notice a bad odor, and I've also been told by my family members that there is a bad smell there.
Does it? Have you been feeling sick?
I have actually been very weak over the past 2-3 months now.
Okay. Does it associated with the decrease in the body weight?
Yes, I have lost a few pounds, to be frank.
It is intentionally or unintentional?
No, it is unintentional. I try to eat as much as I can, but I still have lost weight over this duration.
What's about your appetite?
No, doctor. I'm not able to eat properly as well. I have difficulty. I sort of sense of difficulty in eating.
I can imagine that. Does it is associated with the pain during the swallowing?
Not always, but sometimes yes. Especially when something gets stuck, I have some sort of a discomfort in the chest.
How it affects your life?
I am not able to eat. I'm not able to do my routine activities. I've progressively becoming weak, and this is how it is.
I can imagine how it is hard for you. So, have you had any other same symptom previously?
I have never had these kind of symptoms before, doctor.
Have you had any past medical history?
None that I can think of right now.
Have you had any surgical problem, surgical past history?
I think I had an appendectomy when I was a child, but nothing more than that.
You didn't remember where is it?
No, I really don't remember, doctor.
Okay, no problem. Have you had any? Do you drink alcohol?
I occasionally have alcohol, a pint or two,
How
over the
many
weekend.
units per week? Just in the weekend?
Yeah, over the weekend. It's just a social drinking over the weekend. Maybe a pint or two of alcohol.
Are you smoking?
Yes, I do smoke.
Yeah. How much?
Around a pack a day.
Okay, it's hard. So, what's about your exercise?
I really do not exercise significantly.
Okay, so have you had any allergy to the medication?
Not that I know of.
Do you take any medication?
I just taking some painkillers on and off. That's it.
Okay. Do you have any? Sorry, I need to ask about your. Do you have any same problem with in your family?
No, I really don't have anyone in the family who had this kind of problems.
Who's living with you in home?
I'm living with my wife, and my daughter visits us occasionally.
All right.
Okay.
Can you please present your case now?
So, 44 years old. He's presented
54.
with the difficulty. 54. He's presenting with the dysphagia, no pain for the solid, and it's progressively for solid and fluid. He's associated with the decreased body weight, and also he's smoking, he's alcohol, and he's taking medication on and off for pain and for painkiller, and it's affected his life, and no associated, no vomiting, no heartburn, but it's associated with the bad odor.
So
in
what
the
are the differential
mouth.
diagnoses that you will consider?
It is the neural, or either it is malignancy because it's associated with the decrease of the body weight, or it is also associated with the web, pharyngeal pouch, goiter, achalasia, and also we can.
What investigations would you ask for to confirm your diagnosis?
I will send to confirm my diagnosis. I will do OGD, and
right away.
But all investigation I will send it. I will need to complete physical examination, and I also send for hemoglobin, blood test, full blood count, liver function test, renal function test, clotting, and I will take X-ray. I will take OGD, barium swelling, esophageal endoscopic ultrasound, and also will do.
Considering if patient has esophageal carcinoma, what should be the management or treatment?
The management, according, it is dependent on the where is the site and where is the stage. So it is either resection or resection plus chemotherapy if it is metastasized. So we can self-expanded and palliative therapy and feeding jejunostomy.
All right, good. Thank you. Yes.
Thank you very much.
Dr. Machad, can you please give the feedback first?
First of all, excellent history, sir. Really appreciate it. I'm sorry, I missed on a couple of details there. I think there was past history of testicular cancer, I guess.
Yeah.
But I don't think.
Anything else you felt as a patient, like if you were since you are a doctor here, of the same level, but if you would have been a patient, would you have understood his
I would have understood in a situation of vomiting and the probable ask for hematemesis.
Yeah.
He didn't ask. A leading question would have been a straightforward answer. Probably.
Yes.
Oh, okay. Okay. For this point, just I want to say, I said, are you sick? If you don't, if you said no, you said no. So I cannot ask you about hemoptysis because hemoptysis is associated blood with the vomitings. So you said I'm not vomiting.
Yes, but this question, are you feeling sick? It's not a relevant question to ask.
It's very vague. I mean, I would have understood that, but I could have had a tummy pain, could be sick as well.
No, sickness is anything. That's why he's here. He's with you. That's why this question you should remove from your history-taking catalog.
Can I say something?
Yes, please.
For here as a language. If you feeling sick, that means heartburn.
No.
I feel this is used in the UK. I'm sorry.
Don't use that language.
But when if you say I feel sick, I'm sick. When they said any person you said I'm sick, it's not mean I'm ill.
Okay.
I'm vomiting.
Dr. Yes. If you have come to
this is with my experience here.
Yes, remove that experience from your memory, please.
Okay.
Because if you have come here, then the feedback that I give you, you have to keep that in your mind. And yesterday I requested you that for some stations, you would have to begin from the beginning. You would not do, if I'll post this recording and then you listen. First 40 seconds you wasted. When he told you his identity, patient, then you repeated after the patient. There's no need. Save as much time as you can, because time is your enemy here. You didn't get to finish your history taking, as we all know. And then secondly, there are certain questions. If you had any past medical history, you ask something like that. You say, are you taking medications for any conditions like diabetes, blood pressure, hypercholesterol, like high blood pressure, high cholesterol level, like any layman language, and you mention 3-4 diseases or conditions as well, so that you'll know that patient is having any past medical history at the age of 54. Then you ask if you have any past surgical history. Instead, you can simply ask, have you ever been operated for anything? Like, you make the questions, same questions, but like rephrase them and make them more easier. Some of the questions, some of the things are like this, and in this way you'll save the questions, save the time asking questions. And then you just did ask about halitosis. You didn't ask about the lump or the gargle or the pain. You did ask pain afterwards, but not exactly at that moment. But then right, any you didn't confirm if there was any autoimmune condition like painful cold hands or dry eyes or mouth. If there was any bowel changes you noticed, the patient noticed. If there was any weaknesses anywhere in walking, like do you have any problem walking up the stairs or anything to rule out that. Severity of the swallowing, how bad that is, because now patient told you itself that it has started with food and now it has become with liquid, so it has become worse, so that you knew. Right, and even when I'm asking you about the investigations, or when I asked you about present your history, you should have begun, okay, I took the history of 54 years old male with this problem, and if time would have allowed, I would have completed, because you didn't get to ask idea, concern, and expectation, so that you can mention at that time. So this would have counted, because otherwise this will minus so many points, so many marks at the end. And when I ask investigations, then you should also say, all right, if you wanted to say, because you started with ODT right away, and I asked you right away with ODT, but then you could have said that I would do the complete physical examination, then I'll do all the routine investigations like blood and etc. And then I'll do the ODT as well, because I suspect. And Yeah, and the treatment here was correct. It was correct. All right. Anything else you want to ask?
I just have one question. I have, because you asking about investigation, what is the professional, what is the most likely diagnosis?
Yes.
So I cannot diagnose by the, so I should be put the most appropriate, is the OGD or barium intimate tissue is falling. So I will for that I start that.
Yes.
But I missed the concern, if the patient have any concern or not, I will say this. Yeah.
But then, yeah, you were talking about the social history, who lives with you at home, these sort of question. But then family history you can ask. Drug history, I think you did touched upon that. I'm not sure. Yeah, if a patient is allergic to any drugs or anything.
I asked about this.
Yeah, and I think you asked if patient is taking any regular medications. Yeah. Onset. Oh yeah, you did ask about the pain, if it's associated with pain.
I said associated with pain or not.
You did ask.
He said no.
Yeah.
And I asked about halitosis.
Yeah, that you did. But the lump, do you feel any lump in your throat, or do you have you ever noticed any gargling or wet voice after swallowing? This you haven't asked. So with practice, will definitely will improve. But some of the questions and some of the habits you would have to modify. All right, good. Started your timer, and here is your question. Right, so if you're read and understood, considering the communication skills station, kindly begin.
Hello, I am Dr. George, one of the surgical doctors here. Please, may I confirm your name and age, please?
My name is John. I'm 55 years old.
Okay, Mr. John, I have been asked to talk to you about an investigation we intend to do for you. But first, I would like to ask, do you know anything about this so far? About what we want to do for you and the condition?
Yeah, I've been told that I have a problem with my foot pipe, and I was told that I would need an investigation to understand more about this problem. But I'm not sure about the exact details of this investigation.
Okay. Mr. John, following the test we had done for you before, we want to do what we call an esophagogastroduodenoscopy, OGD in short. What this means is we would put a camera through your mouth to look at your throat, look at your tummy, and also down to part of your gut. This would help us know where the narrowing is and making it difficult for you to swallow. As we put the camera, we'll be able to look at what we are seeing through a TV. It would also give us room to possibly take some samples also.
Okay. And would I be awake during this procedure?
Well, you would be awake during the procedure, but we'll give you some things that will make you not to feel pain.
Okay. And is the procedure associated with any complications?
Do you understand, Mr. John?
Yeah, I understand. Thank you. And are there any complications associated with this procedure?
Hello, Mr. John.
Sorry.
Dr. George, you cannot hear him? We can hear you. Go ahead.
Am I audible to you?
Yes.
Okay.
Hello, Mr.
George? Yeah, am I audible to you? Hello?
Hello, am I being heard?
Yes, yes.
Yes, ma'am, can you hear me, ma'am?
Yes. Continue,
Okay.
Dr. George, please.
Yeah. I think there's something wrong with this connection.
Yes, Mr. John, you had asked if you'll be awake during the procedure.
Yeah,
And
yes.
I said, yes, you
Okay.
would be awake during the procedure, though we'll give you some medications that will make you not feel pain and will make you feel a little bit drowsy during the procedure.
Okay, thank you. Can I know if there are any complications associated with this procedure?
Yes, no procedure is really without risk, but the possible risk that may come up with this one is that while we are putting in the tube, you may have some damage to your teeth. Also, there may be bleeding from the sides. If we're taking some samples, some tissues from the place, there may be some bleeding. And also, one of the things to worry about is there may be an opening, an injury through your foot pipe. This may be a serious complication, but as we would carry out the procedure, we'll be careful enough not to cause you any harm.
Okay. After hearing so many complications, I'm not very sure if I want to go ahead with this procedure.
Yes, I can assure you that you'll be in the best hands. And this procedure has been done for other people before. And we would be careful enough not to make you have any of this risk we have mentioned. We'll be careful enough to avoid that.
Okay, doctor, that is reassuring. Also, doctor, I've been having a lot of salivation lately. What could be the possible reason for that?
This is because of the narrowing. This is probably because of the narrowing that is in your food pipe, whereby when you swallow saliva, it doesn't really, or when you take in things, they don't really pass smoothly. This can make you have regular secretions or salivation from your mouth.
Okay, doctor, I've been doing some reading about my symptoms, and I'm really worried if I am having cancer in my food pipe, doctor.
Well, it is still too early to tell you if this is cancer. Considering the first tests we had done for you, it shows there is a narrowing, but this investigation we are going to do for you would help us get some tissues, which we'll send for further investigations. This will tell us more exactly what it is.
Okay, doctor, and how long would it take to get these investigations, results of these investigations?
It will take an average of 2 weeks for us to get the investigations.
Okay, and so I'll have to wait the whole 2 weeks to find out what is wrong with my food pipe, or?
Yes, go ahead, Mr. John. You would have to wait the whole 2 weeks, but in the meantime, if you have any complaint, for the period we'll be available to help you within the 2 weeks if you have any other concern or complaint while we wait for the results.
Okay, thank you, doctor. And after this procedure, will I have to stay in the hospital?
Well, since we'll be giving you some medications that will make you feel drowsy, you would have to stay in a recovery room for about an hour or two until you're stable enough to go home, and advisably go home with somebody if you're driving, or for the person to drive you home.
Okay, doctor. And again, doctor, coming back to my previous concern about cancer, I've also done some reading, and I've come to know that it is associated with smoking and drinking. And I have been a chronic smoker and an alcoholic. And does this have to do with any of my symptoms?
Well, smoking and drinking, alcohol, large excessive amount of alcohol has been associated with cancer. But for now, like I told you before, we cannot say, it's still too early to say if this is cancer. We'll have to wait until we get the results.
Okay.
Do you have any other concerns, Mr. John?
Would I have to take any precautions before undergoing this procedure?
Okay, before undergoing this procedure, you would, for the morning of the procedure, we would advise, if we plan to do this procedure early, we would advise you do not eat that morning, but you can also take cleft fluids up to about an hour before the procedure.
Okay. 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 Thank you.
All right. If you do not have any other concerns, I would like to summarize what we've talked about.
Please, doctor.
So I have told you, yes, I have told you that we are planning to do a procedure known as esophagogastroduodenoscopy for you, which would entail putting a camera through your mouth, through your food pipe, and into part of your intestine, which we'll also be watching on the television to see if there is anything. In the course of this, we would also take some samples from any of the swellings we see, which will be sent for a test. While we're doing this, you'll be given some medications, which would help you not to feel pain, but will also make you feel a bit drowsy. After this, what we take will be sent for investigations, and we'll wait for about 2 weeks to have the results. Are you okay with this?
Yeah, I'm okay. Thank you, doctor. Thanks a lot.
All right. Thank you, Mr. John.
What should be your last sentence? Yes, if you're okay with this, then sign the consent forms.
Yes, yes, ma'am.
Yes, yes. It was all good, except for the last part. Yes,
Okay,
because this whole counseling you did because you wanted to convince the patient to sign the consent form, right? So at
yes,
the end,
ma'am.
you'll give the consent form. That's good. All right. Any feedback?
Okay.
Dr. Joseph, how did you feel?
Ma'am, it was all good, ma'am.
Yeah.
Yeah. The only thing was, madam, I think he asked my name and age first. I think in communication section, are you supposed to do that? Because
yeah, you have to confirm because the patient was in list, and you have to confirm. You do confirm.
Okay. In communications also we have to confirm.
Yes.
Okay, ma'am.
You have to.
Yeah. Okay. But otherwise, it was all good, ma'am.
It was good. It sounded like a good communication between the two. And he did try, despite the technology problems, sometimes he couldn't hear you. But then it was good. He convinced you in getting to sign the consent paper. Good. All right, started the timer, and here is your question. Right, so if you've read and understood, considering its surgical pathology station, kindly tell me what is your provisional diagnosis of this?
Ma'am, my provisional diagnosis for this patient will be probably a basal cell carcinoma.
Yes. What other conditions would you consider as a differential diagnosis?
For the differential diagnosis, I would like to consider actinic keratosis.
Yes.
Solar keratosis, squamous cell carcinoma, or verruca
Verruca vulgaris. Okay. Can you please describe the lesion that you're looking at right now?
It's an approximately 10 millimeters lesion with central indentation with peripheral. The margins are
what is central?
Central indentation. I'm not able to see an ulceration there.
Okay. All right.
With the margins probably elevated and pearly white.
Yes. What about the surrounding?
There is erythema around the surrounding edges.
All right.
Probably because of subdermal lymphatic subdermal
please tell me, how would you confirm your diagnosis, or how would you make sure that your provisional diagnosis?
In this condition, because the lesion is small, I would like to go with an excision biopsy. Okay. And investigated under a microscope.
Yes. How would you make sure not to leave any deep margins behind?
I could use the MOHS, that's the microscopic oriented histographic surgery, to avoid any deep margin remnants.
Or you'll do the re-excision. Okay, can you please tell me the natural history of basal cell carcinoma? Or does it
the basal cell carcinoma is usually a slow growing tumor arising over the exposed part of the bodies, sun exposed part of the bodies. It is a locally invasive tumor. However, it is very less potential for developing a malignant or a distant metastasis with less perineural and perivascular invasion.
What should be the ideal treatment for basal cell carcinoma that you can offer to this patient?
The ideal treatment would be an excision with a margin of 4 millimeters surrounding it, with probably a primary closure if it's feasible, or a flap, if not a graft. In worse situations, we may try to do it for secondary healing.
All right. How would you suggest if after the removal of the lesion, patient has a gap over there on the nose, on the nostril, how should that be filled?
I would like to do a rotation flap from the nasolabial fold and covering it, hopefully.
All right. Okay, if that new graft does not heal and has an infection, so what is the most common organism that you would suspect?
I would suspect Staphylococcus aureus.
All right, good. Okay, can you please tell me how would you differentiate basal cell carcinoma from actinic keratosis?
Actinic keratosis is predominantly present over the cheek, and there will be scaling around the lesion. However, in basal cell carcinoma, we may have telangiectasia around the lesion. We will have pearly white rolled up edges in a situation of a basal cell carcinoma, not be present with actinic keratosis, and central ulceration is usually commonly seen with basal cell carcinoma.
All right, considering the spread of basal cell carcinoma, can you please tell me or comment on it? What are the processes following which it spreads?
Sorry, I'm coming in.
Considering the spread, you asking me to repeat or move on to the next question?
I'm asking you to repeat the question.
Okay,
now.
Considering the spread of the basal cell carcinoma, can you tell me the stages, the series of?
Initially, there will be inflammation, induration, following which there will be permeation. Initially there will be permeation of the blood vessels or small lymphatics, through which a single cell or a clump of malignant cells get dislodged. These malignant cells survive through the circulation. They end up reaching the target organs, and once they end up reaching the target organs, they can start proliferating there to reach for distant metastasis.
All right, just suppose you excise the lesion of this patient, and after some time, this patient comes back to you and has a swollen lymph nodes, and you take the FNAC, and it reveals that FNAC has lymphocytes and many other bi-lobe nuclei. So how would you interpret that lesion?
This is probably a situation of a Reed-Steenberg cell seen in a Hodgkin's lymphoma.
But what is that?
Sorry?
What is it? Can you explain?
A Hodgkin's lymphoma is a malignancy of the lymphatics and lymph node systems.
Good.
Predominantly occurring in the lymph nodes of the upper body in this situation per se. A biopsy of it will be we will be able to see a bilobed binuclear cell, probably called as a Reed-Steenberg cell. It's also called as popcorn cells. We can actually, after the biopsy, we can try to put the patient on chemotherapy for the treatment of this patient. We can have CHOP therapy.
Yes, continue please.
We can try for CHOP therapy or CHAP therapy.
All right. Okay. All right. Patients with basal cell carcinoma are also susceptible to coagulable conditions. So, what can you suggest to prevent deep vein thrombosis to take place or occur?
In a situation of a deep vein thrombosis, I would like the patient. Initially, there are two methods of handling a deep vein thrombosis postoperatively. If the patient has already developed deep vein thrombosis, then I'll probably start him on an anticoagulant therapy, parenteral, which could be either a low molecular weight heparin or fondaparinux, and maintain his INR, international normalized ratio, between 2 to 3. I would continue this for a duration of 6 months.
How much would you give? How much dose would you recommend?
Anywhere between 1 milligram to 10 milligrams. I would calculate based on the body weight of the patient. We will calculate as 0.5 milligram, 0.2 milligram per kg body weight.
If a patient is a case of recurrent DVT development, what management can you offer to that kind of patient?
In the situation, then we can actually try to do a superior vena cava filter can be inserted.
Very good.
To avoid any further embolization towards the pulmonary or the cardia and the stroke, having a stroke.
What are the complications?
But however, if I
suggesting this SVC filter?
I'm sorry, ma'am. Can you repeat, please?
What are the complications that you should keep in your mind once you are asking for the filter?
The surgery itself may be causing problems. However, the patient can develop a thromboembolic phenomena even after this. We may have a jaundice. And, that's all I can think of now.
What are the contraindications to therapeutic
intervention? If the patient has any bleeding disorders in the past, or if the patient's fibrinogen level is more than 100 milligrams per deciliter, we may not want to give the anticoagulate, parenteral anticoagulation.
Okay. All right, we'll accept this answer as well, but yeah. Right, thank you. I've started the timer and here is your question. Right, so if you have read and understood, considering its surgical anatomy station, kindly identify what are you looking at? What is this number 3, please? Or maybe, please, we begin with number 1, please. Can you identify?
Number 1 is the abdominal aorta.
All right, good. Can you identify number 3, please?
3 is the right common iliac.
All right. Can you please tell me the surface marking of abdominal aorta?
Abdominal aorta, it lies in the midline and joining 2 points. One is 4 centimeter above the transpyloric plane. Another one is
at the level of please tell the complete answer.
At the level of thoracic T12.
Yes.
And the second point is at the level of supracrystal line at the level of lumbar 4 vertebra.
Yes. So what is the transpyloric plane, if you can please explain?
Transpyloric plane is a imaginary line that that lies in the midpoint of supraesternal notch and the pelvic symphysis.
Can you please mention the branches of the abdominal aorta? Both single and paired.
Single branches are celiac trunk, superior mesenteric artery, inferior
Arises
mesenteric
at
artery.
what level, please?
Celiac trunk at T12, thoracic,
Yes.
superior mesenteric artery at L1,
Yes.
inferior mesenteric at L3,
Yes.
midensacral at L4.
And the paired ones?
Paired branches are the paired inferior phrenic artery, middle suprarenal, and renal, gonadal, and then the common iliac arteries.
Can you mention the posterior branches of the abdominal aorta?
There are 4 pairs of lumbar arteries.
Yes.
And at the level of lumbar 1 to 4, and also the median sacral artery.
All right. What about the median sacral artery? It begins at what level?
At number 4 level.
L4. Okay. All right. All right. Okay. Can you please? All right. You identified this. All right. Okay. If we can you please identify all the structures from A to H? What is A?
A is the left renal vein.
Yes.
Sorry, right renal vein.
Right. Okay. What is B?
B is the inferior vena cava.
C?
C is the right gonadal vein.
All right. D?
D is the suprarenal gland.
Left
Sorry,
okay.
left
E?
suprarenal gland.
E?
E is the superior mesenteric artery.
Yes. F?
F is the left renal vein.
Good. G? Quickly.
D is the lumbar vertebra.
Yes. H?
H is the ureter.
Yes. Very good. Quickly. All right. If you can tell me what kind of image are you looking at?
This is the AORTOGRAM of the abdominal aorta and its branches.
Can you mention or tell me identify all the branches from A to L?
A is the abdominal aorta.
Yes.
B and C are the right and left common iliac.
Very good. D and E?
D and E are the left and right renal artery.
Yes.
Then F is the splenic artery.
Yes.
G is the common hepatic.
Yes.
H is the superior mesenteric.
Very good. I
is the gastroduodenal.
J
is the left hepatic. K is the right hepatic, and L is the inferior mesenteric.
All right. Okay. Can you tell me the branches of inferior mesenteric artery?
Yes, ma'am.
Branches of the inferior mesenteric artery.
Inferior mesenteric artery.
Or the territory it supplies.
Inferior mesenteric artery supplies the large gut from the left 1/3 of the transverse colon and below.
All right. Okay. Very good. Okay. Can you please tell me the surface marking of the inferior vena cava?
Inferior vena cava lies on the right side of the abdominal aorta.
Yes.
And it starts from thoracic 8 to lumbar 5 vertebra.
And what are the tributaries of inferior vena cava?
From above downwards, we have inferior phrenic veins, the 3 hepatic veins, then the right suprarenal vein, renal veins, then the right gonadal vein,
yes.
Then lumbar veins and the common iliac veins.
Yes, which lumbar veins? 3rd and 4th. All right, good.
3rd and 4th lumbar veins.
All right, can you please tell me what was this that you were looking at?
This is the CT scan of the abdomen.
CT angiography.
At the level
of showing
at
what?
the level of showing the abdominal aortic aneurysm.
Yes. And how is it? What is the shape of the aortic aneurysm that you're looking at?
It is fusiform.
Yes, and infrarenal. Can you define the term aneurysm, please?
Aneurysm, it is the abnormal dilatation of an artery.
Yes, of an artery. And it could be, what are the types of aneurysm that you know of?
It could be true and false aneurysm.
Okay.
True aneurysm involves the whole layer of the arterial wall.
Yes.
Whereas false aneurysm does not have the whole layer of the arterial wall.
All right. Pathogenetically, or according to pathogenesis, you can also classify a aneurysm into infective and post-traumatic. So what can you tell me about that? Median cystic necrosis. Yes. What type of aneurysm is that?
Cystic medial necrosis usually causes true aneurysm.
Very
and
good.
Post-traumatic causes false aneurysm.
Right. What are the risk factors that cause aneurysm, aortic aneurysm?
The common risk factors are hypertension,
Yes.
secondary to atherosclerosis,
Yes.
which is also caused due to smoking.
Yes.
Then certain conditions like Marfan syndrome, syphilis, and bicuspid aortic valves.
And male gender. Okay. Can you please tell me what is dissecting aneurysm?
Dissecting aneurysm is the separation of the layers of the arterial wall with the progression of the dissection proximally and distally.
Very good. Okay. Right. Good. Well in time. Right. I didn't ask you about the sympathetic chain. That